and we hope to see you again soon next year. Thank you.
Hope to see you and meet you. Blessings. Bye-bye.
Bye-bye. Nice meeting you. Tissue integrity diminishes over time, largely as a result of calcification. Tissue valves are exposed to a variety of calcification sources. Free aldehydes are one of these sources of calcification. They accumulate in the tissue during the glutaraldehyde fixation process and throughout valve storage. Collagen is a structural protein material that makes up 75% of bovine pericardial tissue. Bovine pericardium collagen is multi-layered and multidirectional, helping to give the tissue material strength and flexibility. Resilia tissue is bovine pericardium that has been transformed by a novel integrity preservation technology that virtually eliminates free aldehydes through the combination of two proprietary features. The first feature is stable capping, which permanently blocks free aldehydes in the tissue, preventing calcium from binding in vivo. A sheep study demonstrated 72% less calcium content after 8 months in valves with Resilia tissue. In addition, the COMMENCE surgical aortic trial showed that surgical valves with Resilia tissue demonstrated strong clinical outcomes and excellent durability at 7 years. The second feature is glycerolization, where water is displaced with glycerol, removing the need for preservation in liquid solutions like glutaraldehyde. This prevents further exposure to free aldehyde groups, thus protecting and preserving the tissue's integrity and enabling storage in dry conditions.
Good evening. I think that we have a very interesting session on tricuspid valve. Women in cardiology, all the speakers are women, and this is very interesting also. I think that the tricuspid valve is a very hot issue in clinical practice, and we have to start with the first speaker, Dr. Korkoveli. The topic is tricuspid regurgitation, heart failure staging, and hemodynamic assessment.
Good afternoon. Thank you for being here today. So in the next few minutes, I'm gonna talk to you about an old kid on the block who has become the queen of the ball, tricuspid regurgitation. Right heart failure is a clinical syndrome due to alteration of structural and function of the heart that leads to suboptimal blood flow to the pulmonary circulation and elevated venous pressures. So when we have right ventricular dysfunction, it could be either primary or due to RV function decrease in its contractility, or secondary due to RV pressure or RV volume overload or right atrial remodeling. So the cardiac alterations in patients with right heart failure can vary depending on the cause. However, we have more or less RA or RV dilatation, increased RV filling pressures, and increased CVP. And all these lead to the signs and symptoms of right heart failure that we all know: jugular distension, ascites, liver distension, renal failure, malabsorption, and due to congestion of the intestine. So when the cardiac output of the right ventricle drops, we have a drop in the LV filling, the drop of the left ventricle cardiac output, and due to ventricular interdependence, we have increase in LV filling pressures. So all this results to hypertension, exercise intolerance, shortness of breath, pleural effusion. All these could be symptoms of patients with right heart failure. So in this scheme, in this picture, we can see what we already know, that even though the picture of patients with end-stage right heart failure can be dramatic, in earlier stages, even with severe TR, patients could be asymptomatic or mild symptomatic, and peripheral edema could be the only sign of disease. So tricuspid regurgitation might be a cause or a consequence. So right ventricular dysfunction feeds tricuspid regurgitation, and tricuspid regurgitation fuel right ventricular dysfunction. And the mechanisms associated with right heart failure and TR could be multifactorial, and there have been like more than 200 years since the first recorded description of diseased tricuspid valve to recognize tricuspid regurgitation as a health problem with high mortality. So the Framingham Heart study showed that the prevalence of clinical significant tricuspid regurgitation in the general population reached up to 5.6 in women and 1.5 in men older than 70 years old. Another report showing the distribution of TR in the community, with 50% of TR being due to left valvular disease, and a quarter of that due to pulmonary hypertension. 1.6 million US citizens are believed to have moderate or severe TR, and the year mortality is over 10% in these patients, and more than 160,000 new cases per year are recognized. But while we have 1.6 million patients with TR, severe TR, the surgical procedures annually is less than 8,000. And why is that? Due to excess mortality associated with surgery in functional tricuspid regurgitation. So more than 85% of cases of tricuspid regurgitation is functional. But before going to that, we need to focus in another section, which is called iatrogenic related TR, and it's TR related with the implantation of devices. And we all know that the annual amount of devices that are implanted is increasing yearly. So the TR related to this implantation is increasing also. So this CIED-induced TR, as it's called, can be divided in primary or secondary. Primary is when it affects and interacts with the lead directly, and it can be found up to 40% of cases, while the secondary can reach the 60% of cases, and is a progression of the TR that already exists in these patients. So just keep under consideration when you have patients with tricuspid agitation, RV dilatation, and these patients are going to have a lead implantation or because of a pacemaker or a defibrillator. So we might need to think if we can go leadless, if possible, in these patients. So in this paper published by Dreyfus back in 2015, the authors state the obvious, that functional tricuspid agitation is not a valvular disease. It can be caused by it has different causes. As we said, left-sided heart disease that causes right ventricular remodeling affects the tricuspid annulus, but it can be due to atrial fibrillation, the so-called atrial functional tricuspid agitation. So we need to assess all this, the tricuspid agitation per se, the annulus and the leaflets, the coaptation gap, and the tethering or not of the leaflets before assessing these patients for any intervention. And the authors classified these patients in 3 stages, and based on the stage, they offered the right therapy. So the vast majority of patients having functional tricuspid agitation have heart failure or left-sided heart disease. And FTR due to heart failure is associated with impaired quality of life. And the more studies in the past have been restricted to half ref, but recent data have shown that more than half of all heart failure patients have PEF, and it's something that we need to consider. So these are reports from the past, from like 20 years ago, saying that patients with heart failure with reduced ejection fraction having a worse prognosis, and the prognosis gets worse if the tricuspid agitation is more than moderate. This was a very nice study with a very big amount of patients that had reduced ejection fraction, and showed that the prevalence of moderate severe FTR was 23%. But the author stated that given the fact that the burden of heart failure globally, it becomes bigger and bigger, this percentage might go up. So the FTR is a strong independent determinant of mortality and should be a therapeutic target. This paper has patients with all the subtypes of heart failure, reduced heart failure, mid-range heart failure, preserved heart failure, and it stated the same thing, that the presence of tricuspid agitation, moderate or severe, is associated with worse prognosis. This paper, and I know there are lots of papers, but I need to focus on 3 or 4. So it's for right heart failure, and in this paper, more than 1,000 patients, they were staged based on their symptoms, stage 1 no symptoms, stage 4 right heart failure, and it found that the fact that the clinical stage of right heart failure was an important prognostic factor in patients with right heart failure and tricuspid agitation. And in this paper, the staging was the same. It was patients that were meant to have like a tricuspid surgery, and it stated that patients that were in 1, 2, 3 stage of right heart failure had better outcomes than patients in right 4. We know, but it was documented as well. So pulmonary hypertension, a very specific and very important factor of FTR. As we know, the pulmonary hypertension associated with left heart disease and with lung disease are the most common causes, and we know that up to 88% of patients with reduced ejection fraction having FTR. And when it comes to precapillary pulmonary hypertension in patients with chronic lung disease, when the pulmonary hypertension is confirmed, TR is very common, and the estimated incidence of pulmonary hypertension in these cases ranges between 7 and 26 cases per 1 million adults. So diagnostic workup of tricuspid regurgitation, we need to focus on that. And of course, transthoracic echocardiogram is the first line, but it needs to be a multimodality session to assess the tricuspid regurgitation, but I will leave that to the next speakers. I will focus on right heart catheterization, has a key role to exclude pulmonary hypertension, to differentiate pre from post capillary phenotypes, and finally to define the impact of tricuspid regurgitations. I know you all know these waveforms, just to bring them in your mind. When we go through the right heart cath of a patient with tricuspid regurgitation, we might encounter this waveform in the right atrium. It's the ventricularization of the right atrial pressure. We have a dominant V wave and the steep Y descent, and we have a fusion of the CV waves. And here I need to mention that the height of the V wave does not correlate with the severity of tricuspid regurgitation, which is a common disbelief. Common belief. So in the next picture, we show what we all know as Kussmaul's sign. And what's that? It's the increase of the right atrial pressure during deep inspiration. And it's indicative of impaired RV compliance. So the most important thing when assessing these patients with heart failure and tricuspid regurgitation is to find the right diagnosis, because the right diagnosis will give us the right treatment. So when it comes to restriction and constriction, this is, as you can imagine, very, very important, because not all the patients, not restrictive cardiomyopathy cannot have transcatheter intervention treatment. The root sign waveform, I believe that it was sensitive, but it's not so sensitive and specific for the differentiation. However, the relationship between the RV and the LV during the inspiration, during the respiratory cycle, is very important, and this is what we call ventricular interdependence. So when we have an increase in the inspiration of both the RV and the LV pressure, and an increase in the diastolic pressures as well, we have this is indicative of restrictive cardiomyopathy. On the other hand, when we have an increase in right ventricular pressure, but this does not follow from with an increase in LV pressure, this is a sign of constrictive pericarditis. Ventricular interdependence has sensitivity and specificity more than all the other findings, hemodynamic findings. So it's something we need to focus on, remember. Of course, with the right heart catheterization, we assess the pulmonary pressure, the wedge pressure, which is also important to see if the patient has post or precapillary pulmonary hypertension. And now this is probably the only reference I did echo. So there is a very nice report from Louros back in 2022, if I remember correctly, where it says that when the patients were assessed for having transcatheter intervention of the tricuspid regurgitation, and these that were assessed both with echo and invasively, and they found to have pulmonary hypertension, they had a poor prognosis, but not as poor as the patients that were referred for transcatheter treatment, and they were referred only with an echo positive for pulmonary hypertension, and they didn't perform right heart cath. That means that these patients, we don't perform transcatheter treatment in patients without right heart cath. Not to mention that we have to do the cardiac output, either with FIC or thermodilution, whatever makes us comfortable. And it will be a very brief case of a patient that went for tricuspid intervention in our department, 70-year-old with ischemic cardiomyopathy. And this is his right heart catheterization. You can see the ventricularization of the right atrial pressure and the high PA and wedge pressure. So when it comes to therapy in tricuspid regurgitation, so again, we mentioned many times because we need to focus on the underlying disease. There's no point of doing transcatheter intervention without knowing what's the issue, what's the main cause. And it's the only way to interrupt this vicious cycle of tricuspid regurgitation and right heart failure. So just to conclude, tricuspid regurgitation has been identified as a significant clinical challenge in aging society. A systemic, multi-view and multi-parameter approach is crucial. Patient selection is the key to success, and we should all remember the FTR is not a viral disease and should not be treated like this. And transcatheter treatment is also the future in TR disease, but in very specific patients. Thank you very much for your attention.
Thank you very much. A very comprehensive talk. I would like to do a question. After that, we have discussed. In clinical practice, we see patients with severe tricuspid regurgitation, and after 1 or 2 years, the TR regressed. Not progressed. This percentage is approximately 40%. Do you think that we have some points that we predict the regression or progression of TR after a therapeutic?
Because there are patients that we might see a difference in the tricuspid regurgitation on the echo, but this might has to do with the right ventricle function, because sometimes when the RV fails, then the jet in the tricuspid regurgitation is less. We can't measure it the same as it was when the RV function was good. So this something can happen when we have an RV failure, but what we need is to find these patients before and treat them before. So if I understand correctly, you asked me if what we should find, what we should do in order to prevent. So it depends on the stage we have and the clinical stage and how the patient feels, because sometimes and of course it depends on the etiology. So we need to find what's the issue with these patients, because if it's ischemic heart disease, we need to focus on the ischemic heart disease. If it's a cardiomyopathy, we need to focus on the cardiomyopathy, even put a defibrillator or CRT device and things like that. So I think that the main thing is to focus on what's the main problem of the tricuspid regurgitation, and then if we have done all the guideline-derived things, then we can see if that patient could be referred for something else.
Okay, excellent. The presence also of atrial fibrillation plays a crucial role.
But then again,
then
again, we don't know how to interfere with atrial fibrillation if the patient is a good candidate for ablation. So this is something that needs more all the cardiology specialties, I think, the right heart failure and heart failure.
Or the presence of pulmonary hypertension. This group of patients are
again, we need to define what kind of pulmonary hypertension.
Any comments?
I think that as time goes by, we also use MRI more and more.
Exactly.
And there are MRI indices even of RV diastolic dysfunction now, fibrosis, systolic function you mentioned. So perhaps, and it's not easy to obtain an MRI in all of these patients because there are very many patients, but in some of these patients, and perhaps we can have comments from the audience, the MRI will give us some predictors about how bad is bad.
It's not very easy tool. I mean, it's very expensive, so that's the reason we can't have not every patient, even though they give us lots of details, more than echo. Sorry about that.
Very nice talk. Congratulations.
Thank you.
So just 2 points. The one thing is that women, as you saw, tend to get TR far more than men.
Fortunately.
So there is a sex-specific this entity. Second, and also you mentioned that it's very important to define the etiology because this defines prognosis and treatment. And the third one, and I think this is very crucial too, is that right heart catheter is a very simple procedure and very often
it needs to be done in these patients. We can't have treatment without that, in my opinion.
Very nice talk. Thank you very much. I want to ask something. As you said, the right ventricular function is very important in patients with tricuspid regurgitation because the outcomes are very different if we have a very bad right ventricle. So you have also experience, because you have a lot of patients doing transcatheter procedure for TR. How are you evaluating the right ventricle? Which is your protocol for the patients in evaluating the right ventricle function? With 3D echo, are you doing MRI in all of them or in some of them? Or which are the protocols?
So depending, so because we do lots of, we have new devices and we are part of trials and things like that. Every trial has its own protocol, but most of them, they need a transthoracic echo. What we do, a transesophageal echo, of course, and depending on what other comorbidities, we do a CT scan of the heart, but MRI is not in the protocol. If someone has it, it's okay, but we normally don't do MRIs in these patients routinely.
I mean, for the right ventricle, are you using TAPSE, for example? Are you using
you mean the echo?
Yes, the echo.
Okay, you wanted to go through that. So yeah, so it's the next step. But we do TDIs, we do TAPSE, and we do things like that. But yeah, we do that.
But we have also the Dr. Samargandy. Please, your comments.
Yes, thank you for having me here. I hope my voice is very clear. Yeah, first of all, congratulations on the very nice talk. And it's a very hot topic now, having transcatheter and tricuspid regurgitation of disease. But I think the most important slide that you have presented is from that nice paper saying tricuspid valve isn't a valvular disease. Actually, it's a consequences of multi other factorial. So evaluation the etiology of the TR, starting from the basic echo, TAPSE, PA pressure, and then maybe right heart cath will give you a roadmap where to go with. And I agree with you, like for example, there is a vicious cycle going with dilatation of the RA, the RV, and so. And those patients, unfortunately, they are good until they're not good. So you have to define what is the best point to pick those patients before they go into the last end stage of heart disease. So I think we used to say, for example, rate versus rhythm control in atrial fibrillation, but I think maybe now we're shifting gears, we're looking at the things differently and actually considering earlier ablation. If you catch these patients in the early stage, maybe we just cardiovert them with a very simple maneuver rather than going to the expensive cardio ablation and going with these expensive procedures. So now I think in the last 5 years, everyone is looking at it differently in terms of the analysis, the investigation, and afterward, even the approach, people are going more aggressively targeting the etiology of the problem and the root of the problem rather than the consequence of the problem itself. So very nice talk. I admire the way we approached it. And to add to it, we can also conclude RA-RV coupling. Also, it will also help you sometimes, as we mentioned, the PA pressure and pulmonary hypertension, where to direct. Sometimes you want to help the people, but sometimes you cannot. So having a full image, full perspective, and you direct then or tailor the treatment based on each patient individually.
Okay, thank you. So we have to continue to the next presentation. Dr.